Good morning, good afternoon, good evening. My name is Manuel Monreal. I am internist in Spain, and the title of my presentation is The Treatment of Venous Thromboembolism in Patients with Cancer, Low Molecular Weight Heparins versus Direct Oral Anticoagulants, DOACs. As you most likely know, the results of a recent meta-analysis demonstrated that in patients with active cancer, both edoxaban, rivaroxaban, and also apixaban demonstrated a higher efficacy in reducing the rate of VTE recurrences in patients with cancer compared to low molecular weight heparin to dalteparin. And in the same meta-analysis, two of them, edoxaban and rivaroxaban, had a non-significantly higher rate of measured bleeding, while on the other side, for apixaban, there were no differences. So when overall considered, the DOACs are associated to a non-significantly higher rate of measured bleeding than low molecular weight heparin over the first 6 months in patients with cancer. So according to the results of these randomized trials, current guidelines of antithrombotic therapy recommend that in selected patients with cancer-associated VTE and cancer not located in the gastrointestinal or genitourinary tract, we should treat these patients preferably with a direct oral anticoagulant better than low molecular weight heparin. And my question is for all of you, I will share the answer in the next slides. Do you really think that all patients with cancer and VTE should receive the same therapy, either low molecular weight heparin or DOACs? Is that your current practice? Do you think this is the optimal therapy for your patient, for our patients? Because in a research study that we published 5 years ago in American Journal of Medicine, we demonstrated that the clinical outcome of VTE during anticoagulant therapy in patients with cancer greatly differs according to the site of cancer. 900 patients with breast cancer, at the beginning, more measured bleeds in red than VTE recurrences in black. Same for colorectal cancer, over 1,000 patients. But for patients with lung cancer, over 1,000 patients also, the rate of VTE recurrences, symptomatic VTE recurrences objectively proven, was over twofold higher than the rate of measured bleeding. And in patients with prostatic cancer, again, new results. With this first manuscript, we revealed that the site of cancer greatly influences on the rate of VTE recurrences and measured bleeding. I would like to invite you to enter in our website, rietoregistry.com. is an open access website connected to the Riete registry database. In Riete, we have over 100,000 patients with symptomatic objectively proven venous thromboembolism. And the website, we display a number of interactive graphics that are updated every month according to the new patients recruited in the database. When you consider only patients with cancer, at this very moment in the website, there are over 22,000 patients with cancer and VTE. And this is their rate of measured bleeding in red and the rate of VTE recurrences in blue during the first 3 months. At the end of the 3rd month, the rate of the number of patients that developed that VTE recurrences, 713, was much the same as the number of patients that bled. However, if we go to the first 10 days, at the end of the third month, there were no differences, but at the beginning, the amount of patients suffering major bleeding was over twofold higher than the amount of patients developing VTE recurrences. This is not the only important aspect that our registry reveals. In patients with, if you enter in the website, you have the opportunity to select a filter according to sex, age, a number of comorbidities, and the site of cancer. In patients with lung cancer, at this very moment, over 3,000 patients with lung cancer and VTE, there were no differences in the rate of major bleeding of VTE recurrences during the first 3 weeks, but then the rate of VTE recurrences became twofold higher than the rate of major bleeding. The same appears in patients with pancreatic cancer. Over 900 patients with pancreatic cancer and VTE. The rate of VTE recurrences twofold higher than the rate of major bleeding, same as in patients with lung cancer. But if we go to patients with colorectal cancer, over 3,000 patients with colorectal cancer and VTE, the rate of major bleeding was up to twofold higher than the rate of VTE recurrence. You really think that we should treat patients with lung cancer or pancreatic cancer the same way as patients with colorectal cancer? Shouldn't we differentiate individualized therapy according to the site of cancer? This is for colorectal cancer. But for uterine cancer, over 900 women with uterine cancer and VTE, again, twofold higher rate of major bleeding than VTE recurrences, similar to what happened in patients with colorectal cancer or in patients with gastric cancer. Over 800 patients with gastric cancer and acute VTE, with differences appearing early in the course of therapy. During the first 10 days, there were a higher than twofold higher rate of major bleeding than VTE recurrences. I know this is for genitourinary or gastrointestinal, as has been previously said in the randomized trials. But what happens with other kinds of, or other sites of cancer? In patients with breast cancer, for instance, over 2,800 women with breast cancer and VTE. At the end of the third month, there were no differences between the rate of VTE recurrences and the rate of major bleeding. But during the first 3 weeks, at day 26, the rate of VTE recurrences was up to half the rate of major bleeding. It's not enough with saying at the end of 3 months, there are no differences. It's not enough because during the first weeks, the rate of major bleeding highly outweighs the rate of VTE recurrences. This is for breast cancer. It's not a matter of gastrointestinal or genitourinary. Breast cancer or hematologic cancers, lymphoma, leukemia, myeloma, and so on. No differences at the end of the third month. But on day 14, second week, there were 8 patients developing VTE recurrences, 28 patients who suffered major bleeding. You can enter, I invite you to enter in the website. There is no login required. There is no, it's open access and you can discover what happens in these patients. So, ladies and gentlemen, and this is my last slide. I recommend you, this is not the question, low molecular weight hepatitis or DOACs. It's not that simple because we should be careful with the increased risk for bleeding during the first weeks in most patients with cancer, with gastrointestinal, genitourinary, but also hematologic, breast, and other cancer sites. It is true in patients with genitourinary or gastrointestinal cancers, the rate of bleeding is much more higher than the rate of VTE recurrences, all during the course of anticoagulant therapy. So my conclusions would be low molecular weight heparin, according to our data, seem to be better in patients with colorectal, prostatic, gastric, gastrointestinal, genitourinary, but also breast, hematologic, and other sites, particularly during the first weeks. And the drugs may be better than low molecular weight heparin because they are associated to a higher efficacy in patients with lung cancer, pancreatic cancer, carcinoma of unknown origin, and also in other cancer sites, but not during the first weeks, but beyond the third or fourth week. And that's all. Thank you very much for your attention.